Good evening, all. Am I audible? Somebody to confirm?
Yes, sir.
Good evening, all, and welcome to the ISA online PG class. And today we have got a very interesting topic on local anesthetics, including toxicity. And the class will be taken by our own coordinators of ISA online PG classes, Dr. Nishant Sahay from AIIMS Patna and Dr. Parul Jindal from Dehradun. So I'll request Dr. Arjun Khandelwal and Dr. Monica Chikara to please take it forward.
Thank you so much, sir. Good evening, everyone, and good evening once again to the ISA online PG sessions. Today, again, we have two wonderful set of speakers who are none but our own moderators for the ISA PG sessions. We'll be taking sessions on today's session on local anesthetic toxicities. So may I have the CVs? Am I audible, sir?
Yes, Ankur, you are audible. So the plan for the day will be, Ankur, that Dr. Parul will be sharing the slides, and we will take sessions and take parts of this talk on local anesthetics.
Yeah. I don't have that CV template.
Yeah.
Are the slides visible, Dr. Nishant?
Yes, Dr. Parul. The slides are.
Slides are visible, and Dr. Parul Jindal is working as professor at Himalayan Institute of Medical Sciences at SRHU Dehradun, and he is the president of Dehradun Society of Anesthesiologists. And Dr. Nishant Sahay is additional professor at AIIMS Patna, and he is working actively in different programs of ISM National. And I can tell you, both are very, very young, dynamic speakers, and looking forward to a good class on local anesthetics and how to face your VIVA by Dr. Parul Jindal and Dr. Nishant Sahay. Over to you.
Thank you so much, sir.
Thank you, sir. So this talk is on local anesthetics and how to ace the VIVA. And there are certain suggestions that we might have, and this class will be guiding and trying to look at the various aspects of local anesthetics and their management. Am I audible, Dr.
Yes, sir, you are audible, sir.
Okay, so the next slide, Dr. Parul. Local anesthetic agents are mainly asked in the VIVA VOC examination. However, we searched for various theory question papers, and the theory questions that have been asked on the topic are mainly related to the local anesthetic toxicity. However, there are questions regarding the various methods of prolonging the effect of local anesthetic agents, the prolonging the duration of local anesthetic agents, and herein there are certain recent advances which we might touch. Toxicity of currently used local anesthetic and its management. Mainly, most of the questions have been asked regarding this local anesthetic toxicity only. The signs and symptoms and management of local anesthetic toxicity. There have been questions regarding classification of the LAs, discussion of the mode of action, and lignocaine toxicity. The lipid emulsions that have been used for management of local anesthetic toxicity. So these are the basic questions that have been asked. Next slide, please. In the VIVA VOC, when many times what happens is in the drug table, these drugs are kept, these local anesthetic agents, and there is a UK model for answering or structuring how to describe these drugs. That is known as the QPAM structure. The chemical, uses, presentation, actions, mechanism, then the pharmacokinetics, pharmacodynamics, and special points towards the end. And there are certain suggestions that we might have for the postgraduates, how we might want you to answer the questions when you are given to describe local anesthetic drug. You can just start off with the name and its primary use, its chemical name and classification, availability, the composition of the drug or the vial that has been presented to you, the various physical properties, dilution, storage, and pH, because local anesthetic agents, pH, pK becomes very important. The mechanism of action, you need to describe the various receptors, and pharmacokinetics, the volume of distribution, the pH, pK, the protein binding, onset of action. These are the various pharmacokinetics, and you can base your, you can make a template of how you will describe the local anesthetic agent based on these templates, these pharmacokinetics, and then the pharmacodynamics. Next slide, please. Yeah, so the pharmacodynamics will then have the effect on the various organ systems, the effect on the CNS, the CVS, the various blood vessels, the arrhythmic and arrhythmogenic actions, and on any other system which might be useful. Then will come the drugs, the doses, the routes of administration, the common and the novel uses, the various specific effects and interactions, and lastly, the adverse effects, side effects, and contraindications. But what practically happens is, once you start describing a drug, because the time limit is there for the examiners, they will stop you in between somewhere. So we can just start. Suppose you've been given this drug. Now, suppose the examiner says, describe this drug. Just don't start immediately. Wait for some time. Just look at the vial, look at the information that is given. A lot of information can be given on the vial itself, on the paper itself. So you can just start off like, this is a single-use 50 ml vial of a 2% hydrochloride salt of lidocaine. This preparation also has sodium chloride 6 milligram and water for injection, but this does not have any preservatives. Lidocaine belongs to an intermediate potency and duration amide-amine group of local anesthetic agent with a chemical name of 2-diethylamino N26-dimethylphenyl acetamide. And the monohydrochloride salt, as is present in this solution, has a molecular weight of 270.8. So there are certain figures and there are certain numbers that you might want to remember just to give a good impression. And if you start off with a little bit of history also, that presents a good picture to the examiner. The lidocaine is the first aminoamide type of local anesthetic agent, which was introduced in 1943 by Dr. Lofgren, and its commercial sales began in 1949. So now what we have done is, we have just named the drug and the primary use, that is the local anesthetic agent. We have told about its chemical name and the basic classification. This vial is a preservative-free lidocaine and is available in other vials like 5 ml vials and ampoules also. So these are the other preparations in which it might be possible to get. And because it is a 2% lidocaine, each ml of 2% lidocaine contains 20 milligram of lidocaine hydrochloride. The pH of the sterile non-pyrogenic isotonic solution containing sodium chloride solution is adjusted to approximately 6.5. You are detailing the pH and the specific gravity of 1.036 at 20 degrees centigrade. And then it has been mentioned in the cover itself that it needs to be stored in a cool place away from sunlight, and it should not be frozen. So these are the additional information that you can give. You have to make a primarily you have to mention the use. That is, the first use is the local anesthetic. It is a local anesthetic, but a detailed use can be given, like this preparation can be used for peripheral nerve blocks, epidural analgesia, anesthesia. It can be used. So whenever you are describing uses, it is always good to write or even think in terms of classifying the uses. Now, this drug, this local anesthetic agent, has certain pain-related uses like peripheral nerve blocks, epidural analgesia, pain of IV injection. It is used to prepare the test dose, this preservative-free preparation. It can be used for buyer's block, IV regional anesthesia, to treat chronic and acute pain. It is also used as a component of VIVA, but after that, the non-pain uses can be mentioned, like it is used to obtain the laryngoscopy response as an IV antiarrhythmic agent. It has also been used to treat neonatal seizures. You can add to the list. And if you are able to classify or somehow present some order or some grouping, then you'll be able to remember more, and it comes out also better to the examiner. So these can be the possible uses of the drug that has been given to you. Then comes the mechanism of action. Mechanism of action of local anesthetic agents will be described, but however, when you are describing, you must say that the lidocaine acts on the sodium ion channels on the nerves. It diffuses it in uncharged base form through the nerve sheaths and the axonal membrane to the internal surface of the cell membrane, where it reaches the sodium channels. Before combining with the sodium channels, it combines with the hydrogen ion to form a cationic species. All the mechanism of action that we will just mention here, we will describe later in the due course of the time in this class also. So this is just a basic explanation of the mechanism of action. It blocks the sodium channels mainly in the inactivated and the open states. We'll see what these are, and decreases the sodium conductance, and it prevents the propagation of the action potential in these nerves. So this is how the mechanism of action. If the examiner is still willing to listen to what you are saying, then you must mention the pharmacokinetics. Lidocaine has a pK of 7.9 and at a body pH of 7.4, it is approximately 76% ionized. The protein binding is, you need to know certain things about local anesthetics which are important. pK value is very important. You need to know about the protein binding and the percentage of ionized in the at the body pH. These are little things that you must make a chart of, and you might want to remember also. So the onset of IV action is less than 4 minutes, lasts for 0.5 to 3 hours, and then will come the metabolism. It is dealkylated in the liver mainly by these enzymes, and it has a pharmacologically active MEGX, which is the metabolite, and then it is then inactivated to the glycine xylidide forms. Then you can mention about the absorption, but more or less by this time the examiner might want to stop you also. So before you go into pharmacodynamics, we'll see while preparing the drug, you must prepare for the pharmacodynamics also. The pharmacodynamics, the effect on the various organ systems, what will be the effect of lidocaine on the CNS, CVS, and all these systems you might prepare, you must prepare. After that will come the adverse effects and contraindications. But then by this time, mostly the examiner will stop you. And in the interest of because the class will be very long, we cannot just describe everything here. So the examiner might just ask you, what are the different preparations of lidocaine that you know of? And this is an important question whenever you are picking up or you've been asked to describe lidocaine or lignocaine. Now, lidocaine is the internationally, that is an American name, and it is the international name that has been given to this drug, lidocaine. In UK and Australia, it was called lignocaine, and by 2023, it has been mentioned that the term lidocaine should be used, and the lignocaine name from the labels will be removed in Australia also. So lidocaine basically comes in 3 forms. It is the lidocaine hydrochloride solution. It may be combined with epinephrine, that is the lidocaine hydrochloride solution with epinephrine, or as we have seen, it might be the lidocaine hydrochloride solution, which is preservative free. So you might be asked to describe either one of them. So next slide, please. So the preparation will be the same as we have seen under all those headings. But preservative-free lidocaine will come in 50 ml and 5 ml. The lidocaine with ADR comes in 30 ml. Lidocaine without ADR, but with the preservative, comes in 30 ml. Obviously, because there is no preservation, there is no preservative. The preservative-free lidocaine is a single-use vial, and lidocaine, if there is a preservative, and that preservative is methyl paraben, it is a multiple-use vial, and the manufacturers recommend that approximately up to 10 withdrawals can be made from one vial. But the content, what is the different and important amongst these 3 are the content that is there in the vials of these 3. So a preservative-free xylocard or lidocaine had lidocaine 21.3, that is 2%, that is there. It also has sodium chloride and water. Now, what you should understand is why are all these components present in the vial and what is the function of each. So let us come to lignocaine with ADR. It has the most content. Lignocaine 2% has approximately 20 milligram of lignocaine per ml. It also has sodium chloride 6, and this is to make it isotonic. So sodium chloride is there to make the solution isotonic. That is an isotonic solution. Methyl paraben is a antifungal and a bacteriostatic. So that is the preservative there. In this lidocaine, adrenaline is mixed, epinephrine is mixed. Now, once epinephrine is mixed, epinephrine might be in various strengths. It might be 1 in 1 lakh, 1 in 2 lakh, 1 in 80,000. So this equivalent of ADR might change in the different formulations. Now, once adrenaline is there in that vial, what happens is it oxidizes with oxygen. So there needs to be an antioxidant in that vial, and that antioxidant is sodium metabisulfite. So sodium metabisulfite combines with oxygen before adrenaline before adrenaline does with oxygen to oxidize it. So it converts to sodium metabisulfate. The problem there is that sodium metabisulfate is highly acidic, and as time progresses, more of sodium metabisulfate is there, and the solution becomes more and more acidic, which will have certain problems, as we will see in the later on. There are again concerns regarding methyl paraben, whether methyl paraben can be given, should be given IV or not. Methyl paraben is a fungistatic, and it is present in many cosmetics, even certain fruits. But the problem with it is that it is allergenic, and there are countries which have banned methyl paraben. So the alternative to that would be thymol. That will be the preservative. So there are certain cartridges which are there with the adrenaline and lidocaine, in which nitrogen has been introduced to reduce the amount of oxygen in these vials. So this is the content of the various things. Lidocaine without ADR will be the same. It will have lidocaine and methyl paraben, sodium chloride, and water. So the route of administration, whatever is the route of administration of lidocaine without ADR with preservative, preservative-free lidocaine can be given intravenous, extravascular, epidural, intraosseous, intratracheal. Everything can be given with Zyrocard, that is the preservative-free. But there are concerns regarding use of methyl paraben in the intravascular space. Certainly, it should not be given in the central neuraxial blocks. So the various uses of Zylocard, we have seen it is used for pain of injection and nerve blocks. This you can classify and describe. There are other preparations. Next slide, Dr. Parul. There are various other preparations like viscous, and this is particularly useful for awake fiber optic intubations in which we want to anesthetize the pharynx. It is also used for painful conditions of the oral cavity, and the usual dose is approximately 15 ml undiluted. We use it in the mouth, and if it we may spit it out, and sometimes we ask the patients to swallow it also. There are mouthwashes and oral topical ointments. There are very many topical applications of xylocaine, as we will see. Next slide. So this is another thing that is commonly the examiner might ask, and this has gained importance, especially because of the awake fiber optic intubations. The topical aerosol spray 10% LOX lidocaine, or there is a nasal instillation or spray, and this has become this has been given a lot of importance in the DAS guidelines also. Next slide, please. In which they have mentioned about the awake tracheal intubation. There are 4 aspects to it: oxygenate, topicalize, sedate, and perform. And in the topicalized part, we have to use 10% sprays. Next. So lidocaine 10% spray. Next slide, please. Next, yeah, this one. The last slide, please. Yeah. So you can see how the DAS Difficult Airway Society has mentioned the use of lignocaine spray. You need to give 20 to 30 sprays over 5 minutes. And if the nasal route is contemplated for the awake fiber optic intubation, then we can use a combination of lidocaine and phenylephrine, which they have named it as cophenylcaine, which has 2.5 ml of 5% lidocaine with epinephrine 0.5%. Now, many times what happens is if we are not very happy with the topical spray. Next slide. There are other methods by which we want to anesthetize, and one of the very commonly used methods is nebulization with lidocaine. So there have been studies about the safe dose of nebulized lidocaine. They used 10 ml of 4% lidocaine, and then they noted the peak plasma level, certain authors did, and they noted that even with 10 ml of 4% lidocaine, the peak plasma level was only 1.1 microgram per ml. Here, another thing we should know, the toxic level of lidocaine, which is 5 microgram per ml, is associated with toxicity. So even with 10 ml of 4% lidocaine nebulization, the plasma level was less than 1/4 of it. This is also important when we read about tumescent anesthesia, and with the lidocaine, 5 microgram per ml level of blood level of lidocaine is many times not reached, which is the toxic dose. So the application, clinical application, is that even if a third or fourth nebulization is needed with the 5 ml of 4% lidocaine, we can go ahead with it. So here, what is the toxic dose that has been revised by the Difficult Airway Society? Next slide. By the Difficult Airway Society, and in their guidelines, they have mentioned that the dose for topical lidocaine is 9 milligram per kg lean body weight. And the recommendation is actually based on studies in which the actual dose was 9.3 milligram, but they have chosen the 9 milligram per kg limit as a pragmatic decision to allow ease of calculation. So suppose with the 20 sprays, we are not very confident, or we are not very happy that the airway will be anesthetized, we can safely give nebulized lignocaine, or we can use other methods of using lignocaine, and then the total dose should not exceed 9 milligram per kg lean body weight. Next slide, please. So there are very many other preparations of lidocaine also. We are very familiar with this jelly, which is used to anesthetize and lubricate the urethra for insertion of a catheter. There are gels and topical liquids. Next slide, please. And we even have lignocaine heavy 5%, which now does not have much favor as a good spinal anesthetic agent, but lignocaine 5% heavy has been used for spinal anesthesia for a long time. And recent clinical and animal models and in vitro studies suggest that lignocaine has intrinsic neurotoxic effect, and it is more neurotoxic than other local anesthetics. Next slide, please. Even Hadzik, in its latest edition, believes that reports of transient neurological syndrome and cardiac venous syndrome may be associated with lidocaine in doses greater than 60 milligram, either as a 5% or even as a 2% preparation. So many of the clinicians avoid use of lidocaine for intrathecal administration. There are patches which are used for herpetic neuralgia. There are ointments, ophthalmic solution, ear drops. And the next two slides will just inform you about the number and the plethora of different topical applications that are there for the lidocaine. And these are the next slide also will also tell you that even all these have manufacturer specific dosing and application directives. So probably it might not be very possible to remember all of them, but whatever we see in the common day-to-day life, the students must be aware and should be able to describe those. Dr. Parul? You're muted, Dr. Parul.
Am I audible now?
Yes, yes.
Thank you, Dr. Nishant, and I'll take over from here now. The concerns about and questions about local anesthetics are very popular because the subject can switch readily between the basic sciences and the clinical application. Dr. Sahay has already discussed one of the major drugs in local anesthetics, lignocaine. I'll discuss the second important drug, that is bupivacaine. And there are certain points which you should know, some knowledge which is desired, and something which will give you brownie points. So let's move over to the first drug, the second drug, bupivacaine. Now, if I ask you about bupivacaine, I've shown you the ampule here. What do I want to hear as an examiner? I want to hear that this is a single-use ampule, 4 ml vial of sterile 0.5% heavy hydrochloric hydrochloride salt of 1-butyl-2,6-pipe-chloroxidide. It is a long-acting, high-potency, slow-onset amide group of local anesthetics. It is used for administration in spinal anesthesia. 0.5% means that each ml contains 5 milligram of bupivacaine hydrochloride and 80 milligram of dextrose monohydrate. It is a clear, colorless, and particle-free solution which contains racemic mixture of S and R enantiomers. The molecular weight is 288.4 and the pH has been adjusted to 4 to 6 with a specific gravity of 1.026 at 20 degrees. And as Dr. Nishant said, a little bit of history goes a long way. You can say introduced in 1963 by Eckenhanston. The mechanism of action of bupivacaine is that it diffuses in its uncharged base to neural sheaths and the axonal membranes to the internal surface of cell membrane sodium channels, where it combines with the hydrogen ions to form a cationic species, which enters the internal opening of sodium channels and combines with the receptor. This produces a blockage of sodium channels, thereby decreasing the sodium conductance and preventing the depolarization of the cell membrane. Here, the examiner may stop you and ask you that you have shown me only one use or one concentration of bupivacaine. Is there any other solution available? So you might say that the bupivacaine is available as 0.25%, which is for infiltration and nerve block only. It can be available as 0.75% of bupivacaine with epinephrine 1 and 2 lakh concentration as bitartrate, and which is applicable for epidural and retrobulbar anesthesia and cannot be given for obstetric or spinal anesthesia. Sensicrine as 0.5% can be given. It has bupivacaine hydrochloride, sodium hydrochloride 8 milligram, and methylparaben 1 milligram, which is useful for nerve blocks. The second concentration of bupivacaine could be 0.5% with epinephrine 1 and 2 lakh, which is applicable for nerve blocks, caudal, and epidural anesthesia. The pharmacokinetics has to be described after this. If the examiner allows you, it is into, you have to mention it as absorption. The pK is 8.1, therefore it has a delayed onset, and the percentage ionized at pH 7.4 is 18%. It is 95% sodium protein bound in the plasma to albumin and alpha-1 acid glycoprotein. The volume of distribution is 21 to 103 liters. The metabolism occurs specifically in the liver by N-dealkylation, and primarily it is oxidized to pip-chloroxidide. The N-desbutyl-bupivacaine and 4-hydroxybupivacaine are also formed. Excretion is only by 5% excreted in urine as pip-chloroxidide, and 10% is excreted unchanged. The clearance is 0.47 liters per minute. Now, what are the pharmacodynamic effects? Well, you have to say that it affects two major organs. That is what I want to hear, that it affects the cardiovascular system and has a tendency to cause vasodilatation. It can produce CNS depression and sedation, and it is devoid of antiarrhythmic activity of lidocaine because of its fast in and slow out property, that it binds to the sodium channel fast but dissociates very slowly, and this can lead to produce intractable resistant dysarrhythmias. It binds specifically to myocardial proteins in addition to blocking the cardiac sodium channels, and it also decreases the rate of increase of phase 0 during the cardiac action potential. The mechanism of action we'll discuss later, and you'll have an elaborate explanation about it. In toxic concentrations, the drug decreases the peripheral vascular resistance and myocardial contractility, and this produces hypotension and probably the cardiovascular collapse. The potassium and calcium channels may also be affected at toxic doses. In the central nervous system, we characteristically have a biphasic effect. Initially, the patient has excitation due to inhibition of inhibitory interneuron pathways in the cortex. The patient may complain of lightheadedness, dizziness, visual and auditory disturbances, and seizure activity. While the dose increases, the depression of both facilitatory and inhibitory pathways occurs, which leads to CNS depression of drowsiness, disorientation, and coma. The local anesthetic blocks the neuromuscular transmission when administered intraneurally, and it is thought to form a complex of neurotransmitters, receptors, and local anesthetics. So what is the toxic dose of bupivacaine? 0.5%. It's 2 to 2 milligram per kg. Maximum dose is 150 milligram. The drug acts within 10 to 20 minutes, and the duration of action is 5 to 16 hours. Here, the concentration of other concentrations are shown. What is the toxic doses, what is the duration of action, and how they can be administered. I will not go into the details, but you have to memorize this part. So again, what is the time to two-segment regression? You have to remember that it is 150 to 190 minutes. Now, what are the contraindications of giving bupivacaine? That it is hypersensitivity to the drug or to its component or to the amide anesthetics. If there's infection at the local injection site, in patients with obstetric patients with a paracervical block, or where you're using 0.75% concentration, it is generally avoided because there have been reports where mothers have sustained cardiac arrest because of the administration of paracervical block with 0.75% concentration, and they could not be revived. Intravenous regional anesthesia, intra-articular continuous infusion. In these conditions, we generally avoid bupivacaine. In patients with liver, kidney, cardiac function impairment, they have to be given cautiously. In patients who are acutely ill, debilitated, or with heart block, contraindication has to be present. Now, when I said you want to have some brownie points with your examiners, you can also say that in infants less than 6 months, the low level of albumin and alpha-1 acid glycoprotein results in an increase in the free fraction of bupivacaine. So we have to decrease the dose of bupivacaine here. In patients who have 1-carnitine deficiency, again, even with the low dose of bupivacaine, the patient may have cardiac toxicity. And reports have been there that doses as low as 1.1 milligram per kg of bupivacaine has caused severe toxic reactions. So what happens in an obstetric patient? The local anesthetic appears to cross the placenta by passive diffusion. And this diffusion actually depends upon the degree of plasma protein binding, ionization, and lipid solubility. The fetal and maternal ratio of local anesthetics appears to be inversely related to the degree of plasma protein binding, because only the free unbound drug is available for placental transfer. Bupivacaine with high protein binding has a low fetal-maternal ratio, that is 0.2 to 0.4. So the extent of placental transfer is determined by the degree of ionization and lipid solubility of the drug. So after you've finished giving your monologue and you've ranted about the bupivacaine, the examiner may ask you, what is the difference between the newer drugs like Ropivacaine and Bupivacaine, or Levobupivacaine with Bupivacaine? Ropivacaine, as we know, is a pure S-enantiomer, while Bupivacaine is a racemate. In the structure, what is the difference? That Ropivacaine belongs to pip-polooxidide. Again, Bupivacaine also belongs to this group of drug, but it has a propyl group on the piperidine nitrogen atom, while Bupivacaine has a butyl group. Ropivacaine is less lipophilic than bupivacaine and is less likely to penetrate large myelinated motor fibers. Therefore, it has a selective action on the pain-transmitting A delta and C nerves rather than A beta fibers, which are involved in motor function. They are less lipophilic together with its stereoselective properties. The Ropivacaine has higher threshold for cardiotoxic and CNS toxicity. I'm sorry for so much of literature here, but I thought this slide will help you when you look at it later on. Ropivacaine, the affinity of local anesthetic for sodium channel is related to the length of the aliphatic changes. I will describe the molecular structures later on, and just remember this, that Ropivacaine has a shorter propyl chain and has a duration of action of 150 minutes, while Bupivacaine has an action of 175 minutes, and both the drugs are around 96% protein bound. Ropivacaine has the similar potency to Bupivacaine at higher doses, but at lower doses, it is less potent than Bupivacaine. Compared to Bupivacaine, it has similar pain relief, more quickly return of muscle strength, and less paresthesia, which are the advantages of Ropivacaine. All local anesthetics, apart from being potent vasoconstrictor, cocaine shows biphasic activity, being vasodilators at high concentration and vasoconstrictors at low. The vasoconstrictors at low concentration appear to be associated particularly with the S-enantiomers. It probably exerts greater vasoconstrictor activity than bupivacaine, thereby reducing its potential toxicity and increasing the duration of action. Now, what are the differences between levobupivacaine and bupivacaine? Levobupivacaine is the S-isomer of racemic bupivacaine. It is less neurotoxic, and equally potent. It is known to cause less depression of myocardial activity. And in vitro studies have shown that levobupivacaine protein binding in man demonstrates to be around 97%. Levobupivacaine-induced cardiotoxicity requires a greater dose to be administered compared with the racemic mixture, bupivacaine, and levobupivacaine produces less motor blockade but longer sensory blockade. Levobupivacaine may precipitate if diluted in alkaline solutions. So coming over to the next section, that is the chemical structure and classification of the anesthetic agents. We all have to remember that all the clinically employed local anesthetics are weakly basic in nature. And the ideal local anesthetic properties are that it should be long-acting, better sensory motor separation, lesser systemic side effects, longer shelf life, stability, and less tissue irritation, which can be there. This is an amphipathic structure of a local anesthetic. The local anesthetic generally has three parts: a lipophilic part, an intermediate chain, and a hydrophilic part. The lipophilic part is basically the largest aromatic chain, which is derived from benzoic acid, aniline, or thiophene. Whereas the hydrophilic part is a amino derivative of ethyl alcohol or acetic acid. The intermediate chain, that is the ester or the amide linkage. Now, this linkage defines the various properties of the local anesthetics. The basic mode of biotransformation, that is the ester link, that is Procaine, or example Procaine, are readily hydrolyzed in solution, whereas the amide link drugs are relatively resistant to the hydrolysis. So, amide link drugs are more excreted unchanged in the urine as compared to the ester link. For example, let's take an example, procainamide, which is Procaine with an amide linkage replacing the ester linkage. This is a potent local anesthetic as the Procaine, but because of this amide linkage, it is hydrolyzed much more slowly. Procaine is hydrolyzed in plasma in only a few minutes, but just 10% of procainamide is hydrolyzed in 1 day. So modifying the chain or the structure actually alters its pharmacological property. Suppose if we lengthen the hydrocarbon chain, or we increase the number of carbon atoms on tertiary amines or aromatic rings, this causes local anesthetics to have different lipid solubility, potency, rate of metabolism, and duration of action. If we substitute the butyl group of amine group on the benzene ring of Procaine, it will convert the local anesthetic into tetracaine. And when we compare this, tetracaine becomes more soluble, 10 times more potent, and it has a longer duration of action with 4 to 5-fold decrease in the rate of metabolism. Now, this is a classic example of all the three drugs which are given here. Bupivacaine has a methyl group on the piperidine nitrogen atom of the molecule. When you replace this methyl group with a butyl group, you have a bupivacaine. And bupivacaine is structurally similar to ropivacaine and ropivacaine, but ropivacaine with a propyl group on the piperidine nitrogen molecule. This is an isomer of bupivacaine. Now, the duration of action is associated with lipid solubility, and highly lipid soluble generally have longer duration of action due to decreased clearance by localized blood flow and increased protein binding. All this will be discussed in detail by Dr. Nishant. And in the amino acid series, an electron donating substituents in the ortho or the para position increases the potency. The ester group of drugs are more likely to cause an allergic reaction. Most local anesthetic have a tertiary amine except prilocaine and benzocaine, which have a secondary amine. So moving over to the safer molecules, you have to understand a few terms before we move further. There are few terms like chirality. This is a spatial arrangement of the atoms which are non-superimposable on each other. What is the difference between chirality and enantiomers? Chirality is special arrangements of the atoms, whereas in enantiomers, it is a one pair of molecules which are mirror images of each other and they are non-superimposable. Isomer is a molecule with the same atomic composition, but different stereochemical formula, and hence it has a different physical or chemical properties. Stereoisomers are identical isomers which differ in the arrangement of their atoms in space. And racemate is an equimolar mixture of a pair of enantiomers. Now let's see this example of enantiomers. If you see these structures, they're just mirror images to each other. And because they are mirror images, they have different behaviors in their affinity for either the site of action or the site involving in the generation of side effects. They have different affinity for different ion channels of sodium, potassium, and calcium, and this results in the significant CNS and cardiotoxicity. You see this diagram here. We are showing you the structure difference in this structure with Bupivacaine and Bupivacaine. Here, the methyl group has been replaced by the butyl group, and these are the mirror images of levobupivacaine and dextrobupivacaine. So, before I go further, let me ask you a single question. You can type the answers in the chat box. What are the three parts of the local anesthetic molecule? So the options are lipophilic, intermediate linkage, hydrophilic, hydrophilic intermediate linking, and hydrophilic, lipophilic intermediate linking, and lipophilic. So may we have the answers from the audience?
Kindly type your answers in the chat box. So Parul ma'am, everyone is answering one as the correct answer. If you can throw light on it.
Yeah. So the first, correct answer is lipophilic and intermediate linkage.
Thank you, ma'am.
So let's move on to the second question. Which group of drugs share this basic structure with local anesthetics? The options are histamine blockers and anticholinergics, benzodiazepines, and barbiturates. You can post your answers in the chat box, please.
Only type your answers, please. So again, most of them are answering B as the answer.
No, the answer is histamine blockers and the anticholinergics. The structure resembles identical to the histamine blockers and anticholinergic agents. So let's move over to the second part. Before we discuss the mechanism of action of local anesthetic drugs, it is very important that you understand or revise the classification of nerve fibers and local anesthetics. So according to the structure, the local anesthetics can be divided into several categories. According to structure, it is esters, amides, and quinones. Esters can be two types, benzoic acid or para-aminobenzoic. Benzoic acid, for example, just to remember, is benzocaine and cocaine. It sounds similar. And para-aminobenzoic esters could be tetracaine, chlorprocaine, procaine, and propoxycaine. Whereas in amides, we all know with the two I's, we have the bupivacaine, lignocaine, mepivacaine, and prilocaine. And with the quinones, we have Sympathetic. According to the mechanism of action, the agents acting at the receptors on the external surface of nerve membrane is biotoxin. Agents acting at the receptors on the internal surface of the nerve membrane is scorpiovenom. The agents which act by receptors independent of physiochemical mechanism is benzocaine. And agents acting in combination of receptors dependent on independent mechanism like lignocaine. According to the origin, it could be natural like cocaine. It could be synthetic, which is an amino ester of para-aminobenzoic acid like procaine. Alkylyl esters, benzocaine. Amino ester of meta-aminobenzoic acid, uncaine. And aminoamides, lignocaine, bupivacaine. I'm sure you will not be able to remember most of these things, but at least remember the classification as per the structure and as per the duration of action, that it could be short duration, 2-chlorprocaine, 45 to 90 minutes, intermediate duration, lignocaine, bupivacaine around 90 to 180 minutes, and long-acting bupivacaine, levobupivacaine, and ropivacaine 4 to 18 hours. And the other classification could be an injectable anesthetics or a surface anesthetics like low potency, short duration, procaine and chlorprocaine, intermediate potency and duration, lignocaine and prilocaine, and high potency, long duration, tetracaine drugs. So when we talk about the local anesthetics, the nerve fibers come into play, and you have to understand what are the nerve fibers which are blocked and how do we block them. So nerves are composed of nerve fascicles, we all know that, and the entire nerve is enveloped by connective tissue, which is called as an epineuron. Individual fascicles are delineated as by perineum, and layers are flattened mesodermal cells, which are called as perineural epithelium, which line the perineurium. And the connective tissue inside the perineural epithelium is called as endoneurium. So when a local anesthetic is deposited in the proximity of a peripheral nerve, it diffuses from the outer surface towards a core along a concentration gradient. Consequently, nerves located in the outer mental of the mixed nerves are blocked first, and these fibers are usually distributed to the more proximal anatomic structures than those situated near the core of the mixed nerve and are often the motor fibers. So when the volume and concentration is deposited in the vicinity of nerves, gradually the drug diffuses inwards and blocks the nerves. So how many types of nerve fibers are there? We all know A, B, and C. A is categorized again into A alpha, beta, delta, and gamma. A alpha is basically a motor nerve. A alpha type 1A is for proprioception. A alpha type 1B is also for proprioception. A beta fibers are for proprioception and touch and pressures. A delta fibers are type 3 fibers, which are for pain, cold, temperature, touch, motor, and A gamma are for motor. They are the muscle spindles. A alpha till A fibers are 12 to 20 millimeter in diameter with a conduction velocity of 70 to 120, and they have mild to moderate local anesthetic activity. All the fibers are myelinated in A type of fibers, whereas in A delta, it is type 3 fibers, which is for pain, cold, temperature, touch, the diameter is 2 to 5 millimeter, and the conduction is 12 to 30 meter per second. It has a good local anesthetic activity, and it is also myelinated. Whereas A gamma, they are motor fibers with the muscle spindles, and they have a diameter of 3 to 6 with a conduction velocity of 15:30. B fibers are preganglionic autonomic fibers. The diameter here is less than 3 millimeter with a conduction velocity of 3 to 14, and it is highly sensitive to local anesthetic activity. Some of these fibers may be myelinated. Now we come over to the dorsal root, C fibers and C sympathetic, which are type 4 sensory classification. C dorsal root fibers are basically for pain, touch, warm, and cold temperature. Whereas C sympathetic is for postganglionic sympathetic fibers. The diameters are very less, like 0.4 to 1.2, and the conduction velocity is 0.5 to 2. The local anesthetic sensitivity is very high, and these fibers are not myelinated. So remember, there are two general rules which apply regarding the susceptibility of nerve fibers to local anesthetics. Jitne bhi smaller nerve fibers hote hain, they are more susceptible than the large fibers and are preferentially blocked because of the shorter length of axons, which is required to block to halt the conduction completely. The myelinated fibers are more easily blocked than the non-myelinated fiber because local anesthetics pool near the axonal membrane. This is why the C fibers, which have small diameter but are unmyelinated, are more resistant to local anesthetic. So if you have to remember, just remember one part, that what is the fastest nerve onset? The B fibers are the first to block, then A delta, then A gamma, A beta, A alpha, and then the C. So C is the slowest. And when you have to tell us about the recovery of the nerve block, just reverse the order. So remember the first part, the second part you can automatically tell us. So what is the sequence of clinical anesthesia? The first two block is the sympathetic block because of the vasodilatation, and loss of pain and temperature sensation follow. Next is loss of proprioception, loss of touch and pressure sensations, and loss of motor function. So what happens if the volume we keep constant and the concentration is decreased? If the nerve is thicker, like a sciatic nerve, more the concentration required. As already mentioned, there's a steep concentration gradient which is needed to penetrate the thick perineum. Hence, the block where the nerves are tightly packed, like the sciatic nerve, the success of the block will depend mainly on the concentration of the drug which you're giving. Whereas blocks like popliteal nerve or the plexus, both the concentration and the volume matter. Now, there are two terms which you should always remember. One is the minimum effective concentration of the drug. The minimum effective concentration of minimum effective volume of a local anesthetic is to abolish all the sensory modalities, and this varies according to the site of injection. In short, tighter the space, lesser is the volume required. For example, as I've told you before, sciatic nerve requires less volume than the popliteal. But because of the use of ultrasound, this minimum effective volume has taken a backseat. They say that the minimum volume of brachial plexus can be around 32 ml when you're giving a blind technique. However, the volume may be as low as 1.2 ml or 1.8 to 2 ml per nerve, like radial, under, median, and axillary, by ultrasound guided technique. And some case reports have even reported as around 10 ml use of local anesthetics for the technique. Now, minimum effective anesthetic concentration of Lidocaine can be defined as a concentration at which the spinal anesthetic agent produces surgical anesthesia within 20 minutes of administration in 50% of the patient. Now, coming over to the mechanism of action, may I request Dr. Nishant to please take over?
Yeah, thank you, Dr. Parul. So next important portion is the description of the mechanism of action. Next slide, please. So first of all, what are local anesthetic agents? Local anesthetic agents are those agents that produce a transient and a reversible loss of sensation. You want to be, obviously you want it to be reversible in a circumscribed region of the body, and there is no loss of consciousness, because these are not general anesthetic agents. So local anesthetic agents have been used at various points. It might be used to block the receptor at the receptor level, like we are giving local before an epidural block, we can block it there, or the nerves like the brachial plexus, or the dorsal horn like the central neuraxial blocks. Next slide. These are the various areas by which in which we use the local anesthetic agents. And as Dr. Parul has just mentioned, what we do is whenever we are giving a local anesthetic agent, we are depositing it just above the epineurium, and the poor local anesthetic agent has to traverse the epineurium. The entire peripheral nerve is wrapped in the epineurium, composed of dense connective tissue. Then it has to cross the endoneurium. The individual nerves are bundled into fascicles and surrounded by the perineurium. And after the perineurium is the endoneurium. So each axon is surrounded by the endoneurium. Then it comes to the area where it has to produce its action. That is the axon, the nerve membrane. So what happens is, next slide please. We all know about the local anesthetic. Yeah. So we all know about the action potential in a cell membrane. This is just a basic. Diagram to show how the resting membrane potential is inside a nerve membrane. We see that there is an relative negative charge inside the cell. We all know that is because the concentration of potassium ions is lesser than the sodium ions which are outside. There is a potassium sodium ATPase pump which pushes out the sodium and pulls in the potassium, and this is an active process. And just in case there is an action potential which comes to this nerve, then there is a cascade of sodium ions which comes from outside into the inside, and it decreases the negativity inside the cell, so that an action potential is developed. Now for that, the sodium ions have to come inside. The sodium has to come inside the cell. Next slide please. So once any nerve is stimulated, these sodium channels open and the sodium permeability increases, and the membrane potential, as I mentioned, becomes less negative. Now, if the membrane potential increases enough, as in the case of an action potential which needs to be propagated, then additional sodium channels need to open, and there is a wave which is propagated along the axon or the nerve, and this action potential is propagated. Next slide, please. So what happens in this neuron, what we see is that we have dendrites which is cut, then there is the cyton, that is the cell body. This has been stimulated, and the part A of this neuron has already had an action potential. The action potential has passed, the potassium is moving out. So this is the phase of repolarization of this segment of the nerve. In this segment of the nerve, when potassium is passing out, there is the sodium channels are closed, but the sodium channels adjacent to it in the segment 1, they are open because the action potential is developing there. So there is a cascade of sodium which comes into the cell, and because the portion A is in the absolute refractory period, there is a unidirectional propagation of the action potential distally towards the section P. So in this nerve, if we have to block this propagation of this action potential, we need to block the sodium channels, and these sodium channels are blocked by the local anesthetic agents. Next slide, please. So what we see is that the sodium channels are traversed inside the membrane, and the problem with the local anesthetic agent in preventing sodium entry is that it has to enter the sodium channels from the inside of the cell. So all these local anesthetic agents first have to traverse the lipid layer of the cell before they can get into the cell, and then they can block these sodium channels from inside. So the blocking of the sodium ions is from the inside. The sodium ion channels are in 3 states. Next slide, please. So the sodium ion channels are basically in 3 states. One is the resting stage. Now each of these channels have 2 gates. One is the activation gate and one is the inactivation gate. So when the membrane is resting, as we saw in the action potential where the membrane was resting, it was closed by the activation gate, but this channel is now ready to accept sodium if there is a propagation of the action potential. So now, if a stimulus which is strong enough, a depolarizing stimulus arrives at this channel, the sodium will get inside. It will allow the sodium channels to go in, the channels will open. So now, from the resting sodium channel, now it has become an open sodium channel. Once the sodium channels have gone inside, once the cell becomes in the starts repolarization, then the deactivation gate starts, and these channels are now inactivated. So the inactivation gate closes the sodium channels, and this sodium channel is now no more willing to accept any sodium ions as long as the nerve is in the absolute refractory period. So once all the potassium goes out, the homeostasis of the nerve is maintained till that time, till the absolute refractory period. The deactivation or inactivation gate is inside and it is closing the channel. And during the repolarization, once that is done, then the two gates reset to their original positions, to the resting position. So there are three states. One is the resting stage, second is the open stage, and third is the inactivated state of the sodium ion channels. And what the local anesthetics do is that they combine with all three steps, but they preferentially combine with the sodium ion channels in the inactivated state, and they let it remain in the inactivated state. So this they prevent. So what do they prevent? They prevent the propagation of action potential further. Do they decrease the resting membrane potential? No, they do not, because they're not blocking the open as much as the inactivated. They do block the open also, but they do not reduce the resting membrane potential. They prevent the propagation of action potential in the nerves. This is how the local anesthetic works. They have the least affinity for the sodium ion channel in the resting stage. We will see that these next slide, please. The local anesthetic agents selectively bind to the sodium channels in the inactivated closed stage and stabilize these channels in this configuration, as I just mentioned, and they prevent the opening of the sodium channels to prevent potential from crossing, and they prevent the action potential from propagating. Next slide, please. There is a term which is called use dependent. Sodium channel blockage, reduction in action potential formation and propagation that I have mentioned, and there must be a decrease of 50% of the action potential, therefore before there is a loss of function which is observed. So there has to be a decrease in the 50% of action potential before there is a prevention of propagation of potential. Next slide, please. So as I was mentioning, there is another term which is known as the frequency dependent block. So the local anesthetic agents, they are, as compared to the resting stage, they are more preferentially attached to those nerves in which the sodium channels are opening. So open sodium channels are more susceptible to local anesthetic agents, and the higher the frequency of stimulation, the more will be the intense the block will be. So those nerves which are repeatedly being stimulated, like the sensory nerves, are susceptible to blockade than the low frequency impulses of the motor nerves. So as Dr. Parul was mentioning, there is a differential because of the mental theory that Dr. Parul was explaining. Apart from that, because there is a higher frequency of sensory nerve stimulation, because there is a frequency dependent block, there is a differential motor versus sensory blockage once a local anesthetic is given to a mixed nerve. Next slide, please. So as she mentioned, there are myelinated nerves and there are non-myelinated nerves. These myelinated nerves are having areas which are called the nodes of Ranvier. Now, transmission of nerves stimulus action potential is faster in myelinated fibers, because these areas in which there is the myelin sheath, these myelin sheaths do not have participation of the sodium channel entry. Next slide, please. So there is a saltatory or a next slide, please. Yeah. So there is a saltatory conduction. When the depolarization reaches a node, the sodium enters the node or enters the axon only through these open channels, and these are there at the nodes of the Ranvier. So at the nodes, the sodium entry reinforces the depolarization, and blockage of these nodes of Ranvier are important for blockage of the sensory conduction or action potential propagation by local anesthetic agents. So the apparent leapfrogging of APs from node to node along the axis is called saltatory conduction. And it has been seen that if three nodes of Ranviers, next slide please, if three of these nodes of Ranviers are blocked, then propagation of action potential is blocked. Coming to say that it is not just that the sodium channels are blocked by local anesthetic agents. It has been seen that sodium, apart from the sodium channels, local anesthetic agents also block the potassium channels as well as some of the calcium channels, which are important for the cardiovascular arrhythmias. Coming to the pharmacokinetics, now what we need to understand is that these local anesthetic agents, next slide, so these local anesthetic agents have three portions. There is one amine portion, there is this ester or amide linkage group, and the amine portion of the local anesthetic agent can accept one proton. So anything that can accept a proton or it becomes a base. So local anesthetic agents are weak bases. Now, if you are a weak base, you would like to stay in an alkaline environment. If you go into a toxic acidic environment, you become charged and unhappy and you become cationic. And once it is ionized, it becomes water soluble. So once you are water soluble, you will not be able to move out of the rooms which are made up of lipids, and you are trapped inside that room. So that is known as ion trapping. So in a solution, the local anesthetic exists as a cationic and base form, and this depends on whether it will be cationic or the base form will depend upon the pH or the acidity of the environment in which the local anesthetic agent is. The more acidic the environment, more will be the non-diffusible format of the local anesthetic agent. More alkaline will be the more basic form. The local anesthetic will be able to move around and will be able to traverse all the membranes. So it is better that the local anesthetic agent, if they have to go and transverse the nerve fibers, they remain in the basic form in an alkaline environment. Next slide, please. So as I mentioned, these local anesthetic agents are weak bases. In an acidic environment, they remain more ionized. In the basic environment, they remain more lipid soluble. Next slide. This is important because we will see that the onset of action, how it depends on the onset of action. So commercial preparations of local anesthetic agents. Now what happens is that because they are bases, they are poorly or sparingly soluble in water. So for commercial preparations, you need to have a salt. You have to make a salt of these local anesthetics. So we make a hydrochloride salt and we dissolve it in water. And as I mentioned in the lignocaine, if it is acidic, then there are you need to have preservatives which make it more acidic. If there is sodium metabisulfite, it adds to the acidity. So the pH of the commercially available solutions is quite acidic. Next slide, please. Because of this hydrochloride salt also. This question will often be asked if in your VIVA, if you are given a local anesthetic agent, and the question is, what is pKa? pKa is the pH at which the ratio of ionized to unionized molecules is 1:1. And it is preferable that you remember all the pK values of all the local anesthetic agents. So what happens is like lignocaine. Now the pK of lignocaine is 7.9, and it has a the solution in which it remains is 6. So it is in an acidic environment. It is very ionized. So 99% of the total is in the ionized form and 1% is in the unionized form in this solution. What happens when we give it to the body? It goes inside the body. Next slide, please. The body pH is 7.4. So the ionized portion drops to 76%, And now more and more of the non-ionized, which is lipid soluble, is available. So this local anesthetic now is able to diffuse passively down to the pressure, the concentration gradient. It has to cover the epineurium, perineurium, all those neuriums to get into the muscle, this nerve membrane, action potential, where the sodium channels are. Then it has to traverse the membrane also. So what happens is it goes inside, it processes all the gradients across the membrane. Next slide. And through the cell membrane, in the non-ionized form, it again goes inside the cell where the cell is very acidic. The pH of the intracellular portion is 7.11. So what will happen? This LA, this local anesthetic, will be trapped inside. There will be ion trapping. It will combine with the hydrogen ion, and then it will exert its action on the sodium channels from the inside. So now this will go and block the sodium ion channels, and the duration of action, how long it will remain with the sodium ion channels, will now depend upon the protein binding, how well it is able to bind with the protein. So as you mentioned, as you see, how fast a local anesthetic agent is able to reach this ion depends on the pH and pKa of that drug. The greater the difference, the onset will be slower. If the pK and pH is close together, if the pH at which 50% of it is ionized is closer to the normal pH, the faster it will be able to traverse all these lipid membranes and reach its target area. So onset of action, besides the pK, it depends on a lot of other things also, but pK and pH of the solution is a very important determinant of onset of action and the lipid binding for the duration. So now this practical aspect of pK and pH can be seen in two states. One is acidosis. If there is acidosis, if there is abscess, the area, the pH of that tissue is pretty acidic, and once you put in a local anesthetic, the acidic pH will prevent the local anesthetic from traversing the lipid membranes and going into the intracellular part. So in acidosis, there is a problem with the local anesthetic action. And the second is tachyphylaxis. Now, how can we explain tachyphylaxis? The examiner might ask you. In a continuous local anesthetic infusion, we need to realize that these local anesthetic infusions are quite acidic. So what it does is it uses up the buffer that is there in the local tissue area where the local anesthetic infusion is being going, and slowly, once if the buffering is reduced or removed, then the pH of that area will slowly start to become more acidic, and the local anesthetic dosing required to produce the same effect will be greater. So tachyphylaxis and acidosis can be explained like this because of the pH and pK of the drug. Next slide, please. So as I mentioned, the onset of action depends not just on the pK. There are a lot of other factors. The site and type of nerve, as Dr. Parul has just mentioned. Proximity of the injection, that is a very important thing. And with the use of ultrasound guided nerve blocks and ultrasound guided techniques, we are giving increasingly the drugs are being given in close proximity to the drug to the nerves. The pK of the local anesthetic agent, because if the more the closer the pK to the pH, the faster will be the onset of action, acidity of the surroundings, and very important is the concentration of the drug. Now here, chlorprocaine has a pK of more than 9, but it has a very fast onset of action, and that is because chlorprocaine is given as 3% rather than 0.5 or 0.25%. Is given as 3%. So the concentration of the drug and lipid solubility also might have effect on the onset of action. Next slide, please. So how do we increase the onset of action? We can do that by making the solution more alkaline, and we do that by addition of bicarbonate. And once we add bicarbonates, we now realize the rationale of adding bicarbonate. We want to make the pH more basic so that more of the non-ionized portion of the local anesthetic is available to traverse all these lipid and membranes. So next slide, please. Now comes another part, is the duration of action. So duration of action again depends on a few things. Very important of that is the dose. The larger dose you give, the longer will be the duration of action. Important is protein binding. Earlier it was given a lot of importance, but slowly we realized that protein importance might be protein binding might just be one of those factors. Important is the local blood flow, the intrinsic vasoactivity, whether the patient, whether the local anesthetic has vasodilatory or the level of vasodilatory activity, and addition of vasoconstrictors. These significantly increase the duration of action. Apart from that, what happens is that addition of adjuvants also increases the duration of action. So protein binding, that it is important for the duration of action. The amide anesthetics are primarily protein bound. The pipe collosyllodides like the bupivacaine, levobupivacaine, ropivacaine, these are very highly bound to the alpha-1 glycoproteins. And we know that the free or unbound fraction of the local anesthetic is active. And the protein binding influences the duration of action because of the how tightly it binds to the receptor also. But there are various methods now which are being practiced. Next slide, please. Yeah, so there are newer methods by which it is being tried that we have long-acting local anesthetic agents, and some of that is the liposome-based local anesthetic formulations. And here there is that liposphere that this is called Depofoam. This is a trade name for the encapsulated liposphere. It is called Depofoam. It has a polar core of liposphere which is surrounding and which allows the hydrophilic drug molecule to become encapsulated. You see that this is like a honeycomb, and in this honeycomb there is the water. There are areas of water soluble local anesthetic agents which are there surrounded by this by the encapsules, and this protects from premature degradation by the enzymes, so that these formulations are able to diffuse by very slowly, and the duration of action of these local anesthetics can be prolonged. And recently FDA approval has also been given for surgical site infiltration by this Depofoam. There are other methods like the polymeric micro and nanoparticle formulations. Now, this is another very exciting method of increasing the duration of action, in which nanoparticles are being formed. The advantage of these nanoparticles that it can be individualized. There are certain particles which are metabolized by a certain organ system in the body. So we can target the organ systems by use of these nanoparticle formulations. These are all still in the experimental stages, but these are good to know information for the postgraduates also. There are other controlled release local anesthetics. Okay, so this is the possible advantage of these nanoparticles. Possibility of sustained release, possibility of modifying, as I mentioned, possibility towards targeting to a specific organ or cell system or cell groups. And associated with negligible, obviously it will be associated because the release of these local anesthetics is very slow. Then there will be negligible potential for toxicity. There are other methods. There are other methods of controlled release local anesthetics also. Next slide, please. Which is known as the Saber bupivacaine, that is the sucrose acetate isobutyrate extended release technology. This is a new technology which has developed as a bioerodible injectable depot system, and further the students might read it from the literature. And there is another thing that is the bupivacaine impregnated collagen matrix. So what happens is that this matrix there is implanted during surgery, and it has bupivacaine impregnated into it. So rather than immediate release, these can be sustained release and slow release bupivacaine implants. So these are the ways in which we can increase the duration of action. Just a recap: speed of onset will depend on various factors, but important aspect is the PK. The duration of action will depend on many things. Protein binding is one of the important factors. Apart from that, local the blood vessels around the nerves, these are also important. And potency. Next slide, please. So these certain numbers that we should know, and based on that, we can just gauge what will be the onset of action and duration. So Procaine, Lidocaine, Tetracaine, and Bupivacaine, we know that the Bupivacaine is very lipid soluble. We also see, so the potency, the more the lipid soluble, more potent it will be. So let us see the potency. Next slide, please. So Procaine, if it is 1, then Lidocaine is 4 times more potent because it is 4 times more lipid soluble. Potency is the amount of drug which is needed for to produce that same action. So more lipid soluble, easier it will be able to traverse these nerve fibers, so lesser drugs will be used. So 1/16th of Tetracaine than Procaine, 1/16th of Bupivacaine than Procaine is used because of the lipid solubility. Onset of action, next slide. We see that the PK is 7.9 for Lidocaine and it is more than 8 for the others. So obviously Lidocaine will be more rapid onset than Procaine, Tetracaine, and Bupivacaine. And duration of action, as we see, apart from other factors, it depends on the plasma binding. So Bupivacaine is 90%, Tetracaine 75%, Lidocaine 55%. So Procaine might be short acting, the Lidocaine will be intermediate acting. Next slide, please. And the more than 70%, if it is protein bound, then these will have long duration of action. Next slide, please. So absorption and distribution is influenced by the site of injection. We have seen that IV, tracheal, intercostal, paracervical, this is the rate of absorption of the local anesthetic based on site. Obviously, the absorption will depend on the dosage. If you use epinephrine, there will be local vasoconstriction. This will prevent the drug from being absorbed. And the pharmacological characteristic, the intrinsic vasoactivity will also influence. There are certain drugs which have lung extraction like Bupivacaine and Prilocaine, and lung extraction is influenced by certain drugs like propranolol. So that might have certain effects if propranolol is used in these patients with local anesthetic agents. Next slide, please. Now, Dr. Parul has also mentioned about the placental transfer. It depends on the protein binding. Bupivacaine is highly protein bound, so the placental transfer is less. For other drugs like Lidocaine, the placental transfer is more. And because the esters are very rapidly metabolized by the plasma, in the plasma itself, so the placental crossing by esters is very negligible. There is a concern regarding use of, because of these placental transfers, if there has been a prolonged labor and the fetus is acidotic, then once the local anesthetic goes inside a toxic environment, it gets trapped there and it might produce ill effects because of this iron trapping. So patients, mothers given local anesthetic agents, and if there is fetal acidosis, we might be wary of, we need to be aware of it. Next slide, please. So metabolism, so clearance values and elimination half-life for amide local anesthetic probably is because of its hepatic metabolism. We have seen that the amide local anesthetic agents are very poorly water soluble. They prefer to be, they are not water soluble. You need to have a hydrochloride. So because they are not water soluble, the renal excretion is minimal. And pharmacokinetics of ester local anesthetic agents, as Dr. Parul also mentioned, it is by plasma, by rapid hydrolysis in the plasma itself. And apart from cocaine, all the esters are metabolized in the plasma. Cocaine is metabolized in the liver. Next slide, please. So metabolism of amide local anesthetic agents, they undergo a variety of transformations, and the rate of metabolism through the microsomal enzymes is varying, but all of them are located in the liver itself. Prilocaine is rapidly metabolized. The atidocaine and mepivacaine are intermediate, and the bupivacaine and ropivacaine are the slowest metabolized. They have that pipecolozylidide rings to be metabolized. So individually, next slide, please. The lidocaine it undergoes oxidative dealkylation, and it has an active metabolite which is called monoethylene glycine xylidide, and this metabolite has 80% activity of lignocaine, and it protects against the cardiac dysrhythmias even after the infusion of lidocaine is discontinued. This MEGX, or the monoethylene glycine xylidide, is also believed to offer or confer some of the benefits that are there, which we see after surgeries when TIVA is been given with lidocaine, local anesthetic TIVA is given. So because during TIVA, the benefits that have been seen are because of the blood levels that are there, approximately 1 microns. But once even the blood levels of lidocaine is low, the benefits are seen, and it is believed that the active metabolites of lidocaine might have a role to play in the action there. So hepatic disease or decrease in the hepatic blood flow during anesthesia can decrease the metabolism rate of lidocaine. That is obvious because the metabolism of all these anesthetic agents are there in the liver itself. Next slide, please. Prilocaine is important because prilocaine is metabolized to orthotolidine, and orthotolidine can convert hemoglobin to methemoglobin, and which might be problematic. The dose of prilocaine more than 600 milligram is sufficient to cause methemoglobinemia and reduce the oxygen carrying capacity of the blood. So this needs to be kept in mind. Prilocaine. Next slide, please. Bupivacaine, Dr. Parul has explained everything. There are various pathways for bupivacaine metabolism. There is hydroxylation, dealkylation, amide hydrolysis, and conjugation. And the urinary oxygenation excretion of bupivacaine accounts for more than 40% of the total anesthetic dose. Next slide, please. Ropivacaine is metabolized to 2,6-pipecolozylidide and 3-hydroxyropivacaine through hepatic. This all hepatic metabolism again, and excreted unchanged in the urine is about 1% only. Next slide is next slide, please. These are individual drugs and metabolism. Bupivacaine is the slowest to be metabolized, and there is examiners might ask about the Bupivacaine number, which is unrelated to local anesthesia here. But if Bupivacaine comes up in the VIVA, then you need to know the Bupivacaine number also. Next slide, please. So as I have already mentioned, the esters undergo hydrolysis in the plasma by the cholinesterase enzyme, and except is cocaine, which undergoes hydrolysis in the liver itself. Chlorprocaine is very rapidly hydrolyzed, and that is why even the placental transfer in these pharmacokinetic studies of ester local anesthetic agents is also very difficult because they are metabolized very rapidly. Next slide, please. So renal elimination, because of the poor water solubility, the renal excretion of unchanged drug is less than 5%. The water soluble metabolites of local anesthetics can readily be excreted from the urine. So there is another there's a small question like what is the maximum dose of lidocaine you can use in a 20 kilo boy using 1% lidocaine with epinephrine. So here what we need to understand is what is the maximum dose, permissible dose of lidocaine with epinephrine, and that is approximately 7 milligram per kg. We need to realize that for awake tracheal intubations, the DAS guidelines have said that it should be 9, not 9.3 milligram per kgs. So in the interest of time, Dr. Parul, I think we should move forward. Yeah. So 1%. Yeah. So 1% of lidocaine will have 10 milligram per ml. And
just one person has answered as the option number 5.
We'll see that we'll see that in the slides to come. Dr. Parul. Yeah. So coming to the adjuvants, now this is one portion that that the students might need to work up a little bit, because the adjuvants we have missed, we have not done in this local anesthetic class. Epinephrine, there are various vasoactive amines which are used, which are direct acting epinephrine or epinephrine, levonorepinephrine. These are all agents which are used with as adjuvants. Apart from that, next slide, please. There are certain concerns with epinephrine that we should know. These are the concerns when we are using any vasoconstrictors like epinephrine, levonorepinephrine. There are other adjuvants that are there which are very useful. These are opioids. There are alpha 2 agonists like clonidine and dexmedetomidine, and dexamethasone has been used. Even neostigmine has been used as adjuvants. So that can be a topic for discussion at some other time. Regarding the uses, the regional anesthesia, because this is a local anesthetic agent, these are the mainly the uses that have been covered. It can be classified according to the site, local infiltration. Now, what happens is that when the use of epinephrine and end arteries, there is always a controversy. But the point is that a lot of studies, a lot of the anecdotal reports that have been published, which have used epinephrine and in end arteries, and they have used vasoconstrictor like cocaine, which itself is a vasoconstrictor, which itself has vasoconstrictor. So of late, a lot of practitioners are going ahead with epinephrine and end arteries. They are observing what is the effect of epinephrine, and just in case they are not happy with it, they are using phentolamine also. So these are the drugs which are used. The epinephrine containing solutions for local infiltrations, procaine, chlorprocaine, lidocaine, bupivacaine, these can be used. These are all the drugs and dosages which the students will need to remember. Next slide, please. Another important application is of local anesthetic agents is that of EMLA, that is the eutectic mixture of prilocaine and lignocaine. Now you'll be asked what is the meaning of eutectic mixture. Eutectic mixture is any mixture which, if there is a melting point of two local anesthetics, when you mix them, then the melting point of the mixture will be lower. So that is a eutectic mixture, which allows a slow absorption. Next slide, please. So eutectic mixture is a 5% lidocaine prilocaine cream, 2.5% each, and it acts by diffusing through the skin. Approximately 1 to 2 gram per 10 centimeter square is used under the skin using an occlusive dressing. And then you can do various venipuncture, arterial cannulation. However, it should be used with caution in children, and under 3 months, it is contraindicated because of the concerns with methemoglobinemia. Nerve blocks, we all use it, local anesthetic for nerve blocks. Next slide, please. These are the various concentrations, volumes, and dosing. Another important application is IV regional anesthesia or bias block, and 0.5 lidocaine with or without adrenaline is without adrenaline. Sorry, I'm sorry. 0.5% lidocaine is used without adrenaline. We know that you need to have two tourniquets, a proximal and a distal tourniquet, and there are certain advantages and disadvantages of IVRA. IVRA is a very simple method, and it has a very high success rate of approximately more than 97 to 98%. So it is not something that we can ignore even today. It is one of the most sure shot methods of providing anesthesia and analgesia. The side effects are that it has very limited post-operative analgesia. There are chances of though it is low, but there are chances of toxicity also. And most commonly used drugs are lignocaine, and of late there are studies which have quoted that ropivacaine has a better effect on anesthesia with using the bias block. Next slide, please. So mechanism of action is intravenous is unknown, but it reflects the action on the nerve endings as well as the nerve trunks. So normal sensations, obviously we know that it returns the analgesia also, it becomes painful immediately. We know about the epidural, the uses of local anesthetic in the epidural space. These are the drugs and dosages of the various drugs which are used in the epidural space. Similarly, the spinal anesthesia, we know that we use the drugs for spinal anesthesia, where we need to add dextrose to these solutions. Next slide, please. And the drugs, dosages, bericity, and glucose concentration of the various agents can be read from this table. So there are other uses of local anesthetic agents. There are anti-inflammatory effects. Some people say that there is bronchodilation, and there can be tumescent liposuction anesthesia also, where very large volumes of local anesthetic agents are given. Now, the anti-inflammatory effects of local anesthetic agents is not very well understood. Even there is an article in Anesthesiology Journal in which they have noted about the anti-inflammatory effects. That is a very good. The mechanism is not really known, and the anti-inflammatory action can be because of the effect that local anesthetic agents have on the polymorphonuclear granulocytes. Now, these block the priming of these PMNs, and these prevent the release of the inflammatory mediators from these cells. Regarding tumescent liposuction, very diluted local anesthetic are used, and it is used with epinephrine, and you need to give soda bicarb also. One of the methods of producing local tumescent anesthetic solution is that for 1 liter of solution, you add 1 ampule of epinephrine, then add 50 ml of 2%, and soda bicarb 10 milliequivalent. There are systemic local anesthetic uses for chronic and acute pain also, and for neuropathic pain. So these are certain uses that students will need to study from the textbooks for the exact mechanism. In the interest of time, we'll need to go to the most important part, that is side effects and local anesthetic systemic toxicity. Dr. Parul.
Thank you, Dr. Nishant. The second part I'll speak about is about the plasma concentration of the local anesthetics. We all know, apart from the nerve fibers, the plasma is concentrated also at the central nervous system, the cardiovascular, the autonomic ganglia, the neuromuscular junctions, and the musculature. We all know about the factors determining the plasma concentration: the dose of the drug administered, the rate of the absorption, the site where it was injected, vasoactivity of the drug, use of any adjuvants, and biotransformation and elimination from the circulation. In the central nervous system, we all know that it has a biphasic effect. First, it causes inhibition of the, it causes blocking of the inhibitory pathways, and then it causes excitation of the fibers. So what happens basically, if you see on the left hand side, we have the serum concentration of lignocaine. As the serum concentration of lignocaine is increasing, from an antiarrhythmic, anticonvulsant drug, it starts to become a paresthesia, drowsiness, and muscle twitching, leading to convulsions, then coma and cardiovascular collapse. This is the order or sequence in which the drugs become causes CNS toxicity. Starting from drowsiness, there's paresthesia in the mouth and the tongue, going over to tinnitus and auditory hallucinations, muscular spasm, seizures, coma, causing respiratory arrest, and finally cardiac arrest. The cardiac effects, we all know that local anesthetics inhibit the conduction in the heart with the same rank order of potency as a nerve block. The local anesthetics, they bind with the cardiac sodium channels, that is the sodium voltage 1.5 isoforms, and bupivacaine binds more evidently and longer than lignocaine to cardiac sodium channels. It produces a dose-dependent myocardial depression, possibly from the interference with the calcium signaling mechanisms. These anesthetics bind and inhibit the cardiac voltage channels, calcium and potassium, at concentrations greater than those that which bind sodium channels. The local anesthetics bind beta-adrenergic receptors and inhibit the cyclic AMP formations. So with the cardiovascular system, in case if the patient has a hypercaparic, has hypercarbia, it lowers the seizure threshold and increases the cerebral blood flow, leading to more local anesthetic in the brain. In acidosis also, it impairs the protein binding of the local anesthetic and leads to a more free fraction in the plasma, which leads to more local anesthetic delivery to the brain. Now, there's a very important concept that you all have to understand and remember. What is the cardiac conversion? CC and CNS ratio. Now, this is the ratio of the drug dose required to cause a catastrophic collapse to the drug required to produce seizures. It could be a low, in case if the ratio is low, that means the drug is more cardiotoxic because the central nervous system symptoms are the first to appear. And when you have a central nervous system that the patient complains that he has a perioral sensation, or he is tinnitus, or he's having auditory hallucinations, then that is the time you start giving drugs, and it is spared. The cardiovascular collapse is spared from that one. But if there is a higher ratio, it means the patient has a greater safety margin. What are the risk factors? Extreme age. In child and in elderly, you have to decrease the dose of the drug. In pregnancy, you have to decrease the dose of the drug. With the patients of renal, cardiac, and hepatic, because the drug is metabolized by hepatic and it is excreted in the renal, we have to take care. Now, what are the allergic reactions which are caused by the local anesthetics? The true immunological reactions to local anesthetics are very rare, and true anaphylaxis actually occurs with the estrus local anesthetics. Some of the drugs, they have para-aminobenzoic acid or they have methyl parabene, which has the preservative, and these drugs are more allergic. Accidental IV injections of local anesthetics are sometimes misdiagnosed as the allergic reaction. Around 1980, 2-chlorprocaine was occasionally accused of causing Cauda syndrome, and following accidental large intrathecal doses during while we were giving epidural, we would give into, it would go into the intrathecal space accidentally dura puncture hone ki wajah se, and then these drugs would cause Cauda syndrome. And it was thought that it could be because of the 2-chlorprocaine, but it turned out that it could be because of the sodium metasulfite, which was a preservative, which was added at a relative acidic pH. So there's also controversy about transient neurological symptoms and persistent sacral deficiency after lignocaine spinal anesthesia. So what happens with the musculoskeletal system? If the local anesthetic is directly injected into a skeletal system, it causes myofibril hypercontraction, which leads to lytic degeneration, causing edema of the nerve cells, and finally necrosis. Hematologically, lignocaine has demonstrated reduction of coagulation, and it enhances the fibrinolysis. Lower incidence of embolic phenomena has been reported in patients receiving epidural anesthesia. Now, remembering the adverse effects, they have immunological reaction to local anesthetics are very rare. जैसे हम हमेशा याद करते हैं कि nausea, vomiting, chilling सबके साथ हो जाती है, वैसे ही local anesthetics may be reported to have these: shivering, headache, backache, dizziness, restlessness, anxiety, vertigo, tinnitus, blurry vision, tremors. These are some of the side effects which may precede before the patient complains of or has convulsions, myoclonic seizures, coma, and cardiovascular collapse. So local anesthetic systemic toxicity, this you get as a short note or a full question. The incidence of toxicity is rare. It is 1 in 1,000 to 1 in 10,000. And the site of the administration of local anesthetic influences the risk of toxicity. Depending on the vascularity of the injection site and the technique, toxicity of medication can occur if administering the upper limit of the dosing recommendations. So these are the classical actually site from least to the most toxic site, that is subcutaneous, brachial plexus block, caudal, epidural, and intercostal. But a higher risk of direct intravascular injection like an interscleral or steric ganglion block can lead to toxicity. Increased risk of rapid absorption and toxicity due to injection being in a highly vascularized area like scalp, bronchial mucosa, or pleura can also cause it to have toxicity. Now, this is a beautiful diagram which has been given by Naisora, and you can actually use it as a flashcard to remember everything about local anesthetic systemic toxicity. First of all, what are the factors which will cause last? One is the plasma concentration, that is, in case if you give an accidental partial or venous arterial injection or a total intravascular injection or rapid vascular absorption from a highly vascular site will cause high plasma concentration of local anesthetics. And when this plasma concentration levels are very high, then it may lead to high absorption and it will lead to blast. Now, the rate of absorption of the drug also depends upon, it varies with the tissue, but it depends upon the size of the absorptive surface. Depending on the vascularization of the tissue planes where the drug is injected, an increased dose causes increased plasma level of local anesthetics. As we have told you several times, what is the mechanism at the cellular level? It causes inhibition of the nerve conducting by inhibiting the movement of ions across the voltage gradient. The primary therapeutic agent will be the voltage-gated sodium channel, where inhibition alters the transmission of sensory and motor signals in axons. It also affects the calcium and potassium and sodium-potassium ATPase channels. The non-ionized or the ionized molecules, we know that the inhibition occurs from the intracellular side and requires local anesthetics to cross the lipid bilayer, first as the unbound and then as the non-ionized free molecules. At lower concentration, local anesthetics block the protein kinase signaling induced of tumor necrosis factor A, and at higher concentration, they inhibit the other enzymes and receptors. So we know about the symptoms. What are the neurological symptoms? About 70% patients experience seizures, 10% agitation, and loss of consciousness is seen in 7%. The patient may complain of prodromal symptoms like perioral paresthesia, metallic taste, and tinnitus. About 40% of the last patients may, if you have not controlled so far, may land up into a cardiovascular collapse. Here, the patient may have heart conduction anomalies, decreased cardiac contractility, and decreased systemic vascular resistance. On the ECG, what you can see is an increase in TPR interval and QTC interval, whereas the QRS abnormalities like bundle branch block will appear, and STL intervals with or without refractory bradycardia or tachycardia may take place. Depression of spontaneous pacemaker can rapidly lead to high degree AV block or asystole. Cardiogenic shock follows and refractory hypotension occurs. To diagnose, last can occur immediately at the time of injection or at an hour later. And so you should continue monitoring the patient even after you have given the block for 30 to 45 minutes. Now, what is a differential diagnosis? You have to differentiate between vasovagal, high spinal, total spinal, concomitant disease, or highly epinephrine issues. I will not go into the details because the time is very less. So these are the suggested dosing regimes. What is the maximum dose you can give of bupivacaine, levobupivacaine with epinephrine is 2 milligram, and with epinephrine, without epinephrine, I'm sorry, is 2 milligram, and with epinephrine is 3 milligram. Lignocaine and mepivacaine can be given in fluid as 5 milligram, with epinephrine as 7 milligram per kg, and ropivacaine can be given plain as 3 milligram, with epinephrine again as 3 milligram. So this figure here shows the increasing order of toxicity of the drugs. 2-chlorprocaine is one of the least toxic drugs, while cocaine is the worst and most toxic drug. So how do you manage? हम हमेशा कहते हैं कि जब भी आप manage करते हो, first and foremost is prevention. So you should be adequately prepared with all the anesthetic drugs, and for resuscitation of the drugs should be available. Always give a block ultrasound guided so that you are in the direct vision of giving a block. Check the doses of local and epinephrine before administrating it. Then effective dose should be given in increments if you're giving it through catheters. Aspirate frequently. At times you might have a negative aspiration, and this is not foolproof because the ultrasound probe may be compressing the vein. Monitor the patient while giving a block. After the block, cardiovascular system should be assessed, and IV assays should always be taken before giving a block. Keep talking to the patient and you'll realize if there is something wrong with the patient as soon as possible, and stop injecting. Now, these are the Astra guidelines which have been given for prevention or for the treatment of last toxicity. They say as soon as the signs and symptoms appear, prevent hypoxia, acidosis. And then if the seizure occurs, they should be halted with the benzodiazepine. Benzodiazepines can be given in the dose of 0.1 milligram per kg for midazolam and diazepam, but they do not recommend high doses of propofol and thiopentone. The reason for propofol is that propofol can stop seizures, but the large doses can depress the cardiac function, and it should be avoided when there are signs of cardiovascular compromise. With thiopentone, the dose is 1 to 3 milligram per kg. Now, if their cardiac arrest occurs, they recommend using an advanced cardiac life support with the following modification: that if epinephrine is used, then use small initial doses, that 10 to 100 microgram boluses in adults, and vasopressin is not recommended. Avoid calcium channel blockers or beta adrenergic receptor blockers. In case of ventricular arrhythmias develop, amiodarone is preferred, and treatment with lignocaine is not recommended. So this is totally a contrast from what we learn for advanced cardiac life support in cases of pulses electrical activity. Now, how does a lipid emulsion therapy helps? By the sink theory, just remember it. It sticks to the lipid-soluble local anesthetics and get rid of the drug out of the tissue. However, with the indirect method, it overrides the mitochondrial translocases from the local anesthetic. So consider administrating at the first site of last and after airway management. The dose is 1.5 milligram per kg, 20% lipid bolus, and 0.25 ml per kg per minute of infusion, which should be continued for 10 minutes after circulatory stability. If the circulatory stability is not attained, consider rebolus or increasing infusion to 0.5 ml per kg. Approximately 10 ml per kg of lipid emulsion over 30 minutes is recommended. They do not recommend propofol as a substitute for lipid emulsions. And in case of there is a failure to respond to lipid emulsion, vasotherapy should be started and cardiopulmonary bypass can be taken care of. AAGBI safety guidelines are there, but there are some more different from the Astra guidelines I've gone through. Most of it is same. So what I'll do is I'll just stress on the part which are missing in Astra. This says give 100% oxygen and ensures adequate lung ventilation. Hyperventilation may help in increasing the plasma pH in the presence of metabolic acidosis. They say if there is no circulatory arrest, use conventional therapies to treat hypotension, bradycardias, and tachyarrhythmias. And now the last part they stress upon is the follow-up. They say arrange safe transfer to a clinical area with appropriate equipments and suitable staff unless sustained recovery is achieved. Exclude pancreatitis by regular clinical review. Include daily amylase or lipase assay for 2 days. Report the cases to the advisory. But what I find best is the AURA guidelines, which has been given by the Academy of Regional Anesthesia India. They have divided it into 3 zones. One is stop injecting the local anesthetics, call for help and get a lipid emulsion, activate the cardiopulmonary bypass system. The second step they say is ensure 100% oxygenation via mask or endotracheal tube, treat hypotension, bradycardia, arrhythmias, treat seizures with midazolam or thiopentone. They caution against use of vasopressin, beta blockers, calcium channel blockers, local anesthetics, and propofol. And they use adrenaline in low dose, less than 1 microgram per kg. For the intravenous lipid therapy, they divide it into 2. One, if the patient is more than 70 kg, the bolus should be 100 ml over 2 to 3 minutes. And then an infusion can be sustained with 250 ml over 15 minutes. Whereas, if a patient is less than 70 kgs, the bolus is 1.5 ml per kg over 2 to 3 minutes. And infusion is 0.5 ml per kg per minute. They have recommended a pediatric dose of 1.5 to 2 ml per kg. After 5 minutes, see if the patient is stable. If the patient is stable, shift the patient to ICU and observe him for up to 6 hours. In case if the patient is unstable, repeat the bolus dose, double the infusion, and maximum 3 doses can be given, or maximum dose of 12 ml per kg can be given. Now, I'll just touch the important drugs and what are the important factors important points you should remember, because at times we have some old examiners who have used these drugs, or they prefer they know more about these drugs than us. Like cocaine, it was available from the leaves of erythrooxylin coca, which is a ester of benzoic acid. It is a CNS stimulant. It causes the stimulation of vomiting centers, and it blocks the reuptake of catecholamines, enhancing the sympathetic nervous system activity. So respiration, it increases the respiratory rate, which causes no effect on depth, but at high doses, it depresses the respiratory centers. It may be used as a surface anesthetics, as a topical local anesthetic in ENT, and it has replaced in ophthalmology due to mydriasis, clouding of cornea, and abolishing of the protective eye reflexes. This is the only vasoconstrictor, and the use of adrenaline is contraindicated as it sensitizes the myocardium. Procaine was first introduced by Enhan as first synthetic local anesthetic. It's a vasodilator. It has a high pKa. It is hydrolyzed by pseudocholinesterase to PABA, which inhibits action of sulfonamides. Thus, large doses should not be administered to patients on sulfonamides. Procaine, it is the inhibitor, it has PABA, which is inhibitor of vectorostatic effects of sulfonamides. And it has anti-arrhythmic properties. And chlorprocaine, we all know 2-chlorprocaine is a derivative of procaine. It is more effective, reliable nerve block, and it has a low penetration. It has a brief action, and it is hydrolyzed rapidly 4 times. Therefore, it has low toxicity and no harm to the fetus. It causes hypertension, motor blockage more than the bupivacaine. In the epidural, it prolongs the block and is neurotoxic. The newer chlorprocaine, which contains calcium and EDTA, may cause backache due to tetany of the paraspinous muscles. Bupivacaine, as Dr. Nishant has already told you, it can be asked as a Bupivacaine number. So this is, it is employed as the concentration of 10-5 molar as a differential inhibitor, which will distinguish between the usual and atypical forms of pseudoclonin esterase. Bupivacaine is same potency, onset is similar to lignocaine. It has a good penetration. It has a very potent vasoconstrictor. So there's no need of adding a vasoconstrictor to it. The higher fetal blood concentration due to iron trapping of this drug, due to low pH of the fetal blood and pKa of Bupivacaine. Prilocaine has the same potency and onset as lignocaine. It has a good penetration. It is used mostly in the dentistry as 3% solution and has a rapid metabolism and tissue uptake. It is less protein bind. 600 milligram or 8 milligram per kg dose may cause methemoglobin levels to rise from 1 to 5, and the treatment will be IV methylene blue 1 to 2 milligram per kg. Etodecaine, it has a quick onset, longer duration of action. It has a high motor blockade useful for surgeries requiring intense muscle relaxation. The toxicity is similar to Bupivacaine. It crosses the placenta, has a rapid elimination, and is used as 1 to 1.5%. So one of the important things is what are the future local anesthetics? These are the neurotoxin. By the current knowledge, and as Dr. Nishant has already told us, we have sodium channels, which they local anesthetics, which specifically block the neural sodium channels. The main drawback of the currently available local anesthetic is that they are non-specific blockers or sodium channels. Hence, they are more prone for cardiac and neurological side effects. The affinity of local anesthetics for sodium channel is quite low, and low affinity relates to more systemic toxicity. Now we have the neurotoxins. They have the higher affinity for neural sodium channels as compared to the local anesthetics, and the dissociation constants are in the range of 10-9 to 10-6 as that of 10-4 for the local anesthetics. They are very highly specific to the neuronal sodium channels, hence cardiac and neurological side effects are very low. For example, the affinity of the cardiac Purkinje fiber to neurotoxins is 200 times lesser than that of the exons. They are extremely potent, and hence very small dose of neurotoxins is required to block the peripheral nerves. So one of the most common upcoming neurotoxin is Neo-Saxy Toxin. This Neo-Saxy Toxin is a neurotoxin which is produced by certain species of dinoflagellates and cyanobacteria. The injection of these drugs is responsible for human illness known as paralytic shellfish poisoning. Neo-Saxy Toxin differs from saxitoxin by the addition of an oxygen atom, wherein the hydrogen at this nitrogen 1 of saxitoxin is replaced by hydroxyl group. So the new saxitoxin has been shown to be more potent than saxitoxin, both in vitro and in vivo. So with this, we end our local anesthetic discussion. There are so many things that they are still left, but we could not cover it in this long session. So if we have any question, we'll be happy to answer.
Thank you, Dr. Parul and Dr. Nishant, for this comprehensive talk on local anesthetics. Yes, it's a big chapter and you have done full justice to the talk. I would just take up few queries from the chat box if I am permitted. Can I go ahead, Dr. Parul and Dr. Nishant?
Yeah, sure, Doctor.
Yeah. Dr. Aishwarya has just requested to show the QPAM score. Dr. Nishant, you had mentioned about QPAM score, CUPAM. You can show it again.
Yeah, just a minute. So QPAM score is actually given by FRCA. People who are preparing for FRCA, they would like to listen to this question, listen to the drug rant on this format. C, which stands for chemical composition of the drug, U, which stands for the uses, especially the primary use of the drug which is given. P is for presentation, how it is available, what is the action of the drugs, where it is acting, what is the mechanism of action, and then finally P stands for the last part you can conclude with pharmacokinetics, pharmacodynamics, and the special points.
Thank you, Dr. Parul. It's a well-managed structure where you can remember a drug and go ahead in presenting your answer in exam. Second query is by Dr. Mona. Are there any specific guidelines by ISA or ASA to suggest mandatory use of local anesthetic sensitivity testing?
No, so far there are not no more guidelines from the ISA or the I should say ASA, but there are some guidelines by the French Association of Anesthetists, and they have recommended the use of or giving a local anesthetic before actually giving a skin testing should be done before actually going ahead with a giving administration of the local anesthetic drug.
Thank you, Dr. Parul. Yes, there are no specific guidelines, but it's a good practice to go ahead with doing local anesthetic sensitivity test before you actually administer it. So another is queries by Dr. Jashan. The query is, what is the effect of addition of opioid to local anesthetic? Is there any effect on the duration of local anesthetic blockade?
Yes, so the opioids have been added to central neuraxial blocks for quite some time. You know, we add this fentanyl, and even for epidural spaces, we have our choice of either morphine or fentanyl. So definitely these increase the duration of action of the analgesia, but the mechanism of action is there separate. It is not mediated via the sodium channels. And the choice of also local anesthetics, what we need to give, because we need to understand one thing is that the epidural space is quite vascular. So if we are giving more lipid soluble opioid like fentanyl, then the analgesia is by rapid absorption into the blood vessels. Morphine is the most frequently used, very commonly used opioid. Apart from that, for peripheral, this is for central neuraxial blocks only, no?
Yes, sir. Yeah.
Yeah. So yes, it does prolong the duration of action.
Thank you, Dr. Nishant. Well answered. Next query is by Dr. Mona. Can dexmedetomidine be used intrathecally?
No, it has not been approved by FDA so far. But there have been many studies, research has been there, many case reports have been published about its use in intrathecally. And Dr. Nishant, I think, has a different opinion about that.
No. I have the same opinion. FDA has not approved yet, but yeah, it is being used, and it has been found to be very useful also.
Yeah, FDA has not approved it, but yes, off-label, it's being widely practiced for it being used as an adjuvant in central neuraxial blockades. So last query is by Dr. Mohan Pathak. What is the usual incidence of neurological deficit with neuraxial lignocaine?
So lidocaine, lignocaine, spinal anesthesia is discouraged these days. Exact some incidents, like I searched on the internet, it came out that 1 in 7 patients with lidocaine spinal anesthesia has transient neurological symptoms. So that if you want to know the incidence, it is close to 13%. And
actually, with the lidocaine, what happened was that when the patient was in the lithotomy position, there was a continuous spinal catheter which was inserted. So there was pooling of the local anesthetic at the site where the pressure points were there, and it led to caudal equianal syndrome. So there's no clear-cut definition. There's no clear-cut idea why it happened, or it was blamed totally on the local anesthetic like lignocaine. But because of this incident, the drug use has not been encouraged now.
Thank you, Dr. Nishant and Parul, for responding to the query. Yes, the usual incidence has been somewhere between 10 to 15%, and that's why it's not being encouraged to use nowadays. I thank again Dr. Parul and Dr. Nishant for your comprehensive talk on local anesthetic. It's been an absolutely masterclass session on this topic. I don't find any more query. Over to you, Dr. Naveen Malhotra, sir. Dr. Malhotra, sir.
Yeah, I think it is quite late. You know, we've overshot quite a lot. This topic was actually such a huge topic.
Yeah.
That you know, even with our preparation, we have overshot it by a huge amount. So.
No, that's absolutely fine. This session is going to be very, very useful when it will be viewed and reviewed again and again by the postgraduates. And yes, we have crossed our time. That's not a big point. We would now like to end the session. So thank you again, both the speakers, and thank you audience for your patient listening. We'll be back again on next Monday with another wonderful topic with another sets of speakers. Thank you so much.
Thank you, Ankur.
Thank you, sir.
Sir, thank you, Ankur.
Thank you, ma'am.